Uh, Assalamu alaikum, everybody. My name is Ibrahim Alodhaibi. I'm a fourth year medical student. And today I will be teaching you guys about hemostasis and thrombosis. Like I mentioned earlier, it's a little bit of a difficult lecture. There are some very high yield concepts, but inshallah, by the end of this, you're all going to understand it. Let's begin. So, what is hemostasis? Basically, all that hemostasis is the process that our body has to stop bleeding. And so the final thing that is formed at the end of hemostasis is something called a thrombus or a blood clot, which is just something that contains blood cells and strands of fibrin. And we're going to discuss what fibrin is and all of those things. But reality, what it really ends up being is that hemostasis is the process that our body has to stop bleeding because we need to stop bleeding when it happens. Now, here's the foundation of what makes up hemostasis. And foundation, not the block, the foundation of hemostasis. I don't want to scare you guys. I know the final is soon. So first and foremost, we have the integrity of the blood vessel. If the integrity of the blood vessel is damaged, that means that there's going to be a trigger of hemostasis, right? The second thing is a normal platelet count and function. Now, you guys you're aware of what platelets are and what they do by now, right? I'm assuming yes. Cool. Awesome. Thank you. So you need to have a normal platelet count, but not only does the number need to be normal, your platelets need to be functioning properly in order for hemostasis to work. Last thing is that you need to have the normal level and function of coagulation proteins. And throughout this lecture, we're going to talk about what those coagulation proteins are. All right. Now, first, let's talk about what happens when you have an injury. All right. And how this entire process is going to start. The first thing that we have is, all right, the trauma occurs. Let's say you fell and scraped your knee. All right. You're going to start bleeding. The very first thing our body does before even hemostasis begins is something called reflexive vasoconstriction. All right. And vasoconstriction is just your blood vessels narrowing. So two things are released at the site of injury when there is an injury. And it's something called endothelin. And then also the nerve endings in that area release certain things to cause vasoconstriction. That way your blood vessel narrows and there's not as much bleeding. And then we're going to begin something called primary hemostasis. Now, I know these pictures and the slides are a little bit complicated. I can reassure you guys that you're not going to have to learn every single thing in these slides. It's just that a lot of diagrams in medicine tend to be very complicated. But what primary hemostasis is first the platelets, right, are going to come and they're going to say, all right, this area is bleeding. We need to stop that. Our job is to stop this bleeding. So they're going to adhere to the area, and that's what's happening here. The platelets are then going to change their conformation, right? They're going to become flat and they're going to release granules. These granules that they release are called ADP and thromboxane A2, right? And ADP is adenosine diphosphate, which is the thing before ATP. So that's a little fun fact for you guys. These two things, ADP and thromboxane A2, are going to basically recruit more and more platelets to come to the area, and they're going to form a plug. So the primary goal of primary hemostasis is to form a platelet plug. All right. We just want to make almost like a physical barrier of cells in the area that's bleeding to stop that bleeding. Okay. Is everyone clear for that? All right. So moving on. Now this is a question for you guys, and I'm going to have questions sprinkled throughout the slides. What does a defect of primary hemostasis mean? Perfect, Zach. That means there's no platelet plug being formed. So primary hemostasis, the goal of that is to form a platelet plug. Also, you're going to see a lot of Pokemon throughout this lecture. It's kind of my thing. I'm wearing a Pikachu shirt. Moving on. Oops, slides are not there. Here, endothelial injury. See how complicated this looks. It's again a diagram that's very confusing, but you guys don't need to know all of that. As for the things that inhibit thrombosis, we're going to focus on that later in the lecture. Right now, we're going to talk about the things that favor thrombosis. Really, all I want you guys to take away from this slide is this, that when there is an endothelial injury, something called tissue factor becomes exposed and released. All right. And tissue factor is very, very important because it basically, hold on, let me just explain something again, just to make things a little clearer for you guys. Throughout our blood flow, there are things constantly moving around that are preventing clotting from happening. All right. You don't want clots to be happening when clots don't need to be happening, right? And like I said, we're going to talk about that later. However, the second there is an injury to the blood vessels, right, thrombosis or the things preventing thrombosis are all going to get inactivated. And then this tissue factor thing that I just mentioned, it gets exposed from the endothelial cells, which are these cells over here. All right. The tissue factor gets exposed, and then tissue factor is going to be the thing that favors thrombosis. It favors the formation of blood clots, and it's going to start something called secondary hemostasis. All right. Did you guys all understand that? I feel like I stopped myself in the middle and started a new concept. I want to make sure it's clear. I didn't get it. All right. So no, that's fine. Basically, in the normal, and normally in our body, right, when blood is flowing and things are moving around, we don't want blood clots. We do not want blood clots to get formed because we want our blood flow to form normally. The only time we want blood clots to be formed is if there's an injury to the endothelium, right? So we have these proteins in our blood that are constantly flowing that are preventing blood clots from being formed. However, the second that there's an injury to the endothelium, all of those proteins that are preventing the blood clot from getting formed get inactivated. They stop working, and something called tissue factor gets exposed. And the exposure of tissue factor is going to be what starts secondary hemostasis. And we're going to talk about what secondary hemostasis is in a bit. All right. But really, the main takeaway from here is that tissue factor gets exposed upon endothelial injury, and it's going to trigger secondary hemostasis. Does that more clear? Okay, awesome. So let's talk a little bit about tissue factor. Okay. Basically, this is exactly what I just said to you guys in a bullet note form. Tissue factor is exposed from endothelial cells. It favors thrombosis and it begins secondary hemostasis. All right. And here's just the steps, really, really general steps of the whole entire thing. Remember, we said there's an injury. So you're going to have reflexive vasoconstriction, right? Then you're going to start primary hemostasis by forming this platelet plug. Then you're going to have secondary hemostasis, which we're going to talk about. And then after the plug is formed, you have to get rid of the plug. So we're going to have something called fibrinolysis. Cubchu? Yeah. I see a fellow Pokemon fan in the chat. All right. You guys all understand tissue factor, right? These are like the big 3 points you need to know about tissue factor. Is that cool? Is this for the homeostasis lecture? Yeah, this is homeostasis lecture 1 and 2 from Dr. Rehan. I'm not sure if you guys took it yet, but this is going to be the whole entire homeostasis. All right, you guys get tissue factor? Okay, cool. You're good, you did. So tissue factor starts secondary hemostasis. Exactly. Tissue factor is going to be the thing that triggers the start of secondary hemostasis. So injury, vasoconstriction, platelet plug is formed, tissue factor gets exposed, secondary hemostasis starts. Is that cool? We got it? Awesome. Moving on to the next thing. Here we go. Secondary hemostasis. So remember in primary hemostasis, when I told you guys that the platelets flatten and they change their shape and they aggregate together to form that plug. So in secondary hemostasis, or sorry, in primary hemostasis, those platelets were flattened, they're adhered to the wall. They create something called a phospholipid surface, all right? And really all that means is that the platelets are creating a surface that is appropriate for secondary hemostasis, because secondary hemostasis requires a phospholipid surface in order to begin, okay? Now, secondary hemostasis is ready to begin. And the end goal of secondary hemostasis is to form something called a fibrin plug. And we're going to talk about what a fibrin plug is throughout the lecture. What's most key about secondary hemostasis is that it relies on something called clotting factors. And there are a bunch of Roman numerals and stuff, and there's very confusing diagrams, but we're going to go through it. So again, secondary hemostasis is going to form a fibrin plug, and secondary hemostasis requires clotting factors and a phospholipid surface from the platelets. I spelled platelets wrong. Does that make sense? Awesome. So next is a question for you guys. First, answer this. What is the primary goal, or what is the end goal of primary hemostasis, and what is the end goal of secondary hemostasis? All right, so platelets, sure. Platelet plug, and then fibrin plug. Perfect. So the end goal of primary hemostasis, we said, is to form the platelet plug. All right. This end goal of secondary hemostasis is to form the fibrin plug. Exactly. Primary, you're forming the platelets, and the platelets are providing that phospholipid surface so that in secondary hemostasis, we can make the fibrin plug. Okay? Did everyone get that? Cool. Now, let's talk a little bit about the physiology of platelet plugs. So here's a drawing that I made. I think it's really good. And we're going to talk about everything that goes into forming a platelet plug, all right? And it's a little bit confusing. So again, if you guys don't understand anything, stop me and I'm going to re-explain it. But first and foremost, there are two main things that go into forming a platelet plug, which is platelet adhesion and platelet aggregation. Okay, so let's start by talking about platelet adhesion. So over here, these little pink circles is a platelet. And these platelets have different sort of receptors on them, all right? This green receptor over here is called GP1B, okay? And GP1B, what it does is it binds to something called von Willebrand factor. And von Willebrand factor is something that gets exposed from the subendothelium when there's an endothelial injury. So you can see here, the endothelium is here, and it got damaged. So the von Willebrand factor got exposed, all right? And so what's going to happen is the GP1B that's present on platelets is going to go and bind to the von Willebrand factor. And that's the first step of forming a platelet plug, all right? That GP1B is binding to the von Willebrand factor, and now the platelets are able to adhere to the damaged vessel. So do we get GP1B and von Willebrand factor? Yes. Yes, yes, yes. Yes. What's the result? So the result, and we're going to talk about this now, is that because platelets are now adhering to the correct area, they are able to sort of call over other platelets and be like, hey, this area is injured, right? We want to aggregate and get as many platelets into this area because we need to stop the bleeding. So what's going to happen is that more platelets are going to come to this injured area. And the other receptor that's present on platelets is this blue one over here. And this is called GP2B3A. I don't know why they're named like this, but those are the names. And between the two GP 2B1A receptors comes in something called fibrinogen. And fibrinogen kind of acts like the glue between those two receptors so that all of these platelets can come together and start aggregating to form a plug. All right. So the main idea here, I'm going to clear the pen. The main idea here is that in order for platelet adhesion to happen, you need von Willebrand factor and GP1B. In order for the aggregation of platelets, you're going to need GP2B3A and fibrinogen. Do you guys get that? Do platelets attract other platelets with ADP and thromboxane? Yes, they do. Fibrinogen is inactivated. Yes, fibrinogen is the inactivated form of fibrin. Is this clear to everybody? I got it. Awesome. Is anyone confused about this? Because right now, this is what normally happens in the body. And the next slide, we're going to talk about some diseases that you need to know for your exam. So I want to make sure, in order to understand the diseases, you need to understand the normal physiology. Makes sense. Okay, good. Okay, really good. I struggled a lot understanding this in first year. So I'm glad that you guys were able to get it. Okay. No one's saying anything, so I'll continue. Just one little correction I want to make. I think I said von Willebrand factor gets exposed from the subendothelium. Forget I said that. The actual thing that's happening is that von Willebrand factor is getting released by the endothelial cells. All right. Just want to make that clear. All right. Will we get the slides? You will get the slides, and I also have written notes under each slide explaining everything. So I will send you guys the slides when I finish the lecture. All right. With that being said, let's talk about the pathology. All right. And so here's a picture that pretty much simply explains it. We're going to talk about each of the three diseases here. First, I want to talk about Bernard-Soliere syndrome. All right. Bernard-Soliere syndrome, right, is an inherited disease where you do not have GP1B. And because you do not have GP1B, let's go back, you're not able to do platelet adhesion. So Bernard-Soliere syndrome is an issue with platelet adhesion. So I'm just going to write that here. I don't know why I can't spell platelet today. Platelet, that's not right. Adhesion issue. All right. It is right. Oh, okay. Next is something called Glanzmann thrombasthenia. And Glanzmann thrombasthenia is just that you don't have GP2B3A. And if you don't have GP2B3A, you're going to have an issue with platelet aggregation. All right. So Bernard-Soliere is GP1B deficiency. Glanzmann thrombasthenia is GP2B3A deficiency. All right. One is a platelet adhesion issue. One is a platelet aggregation issue. Both of these issues means that you cannot form a platelet plug, which means it's a problem of primary hemostasis. Okay. We understand Bernard-Soliere and Glanzmann's thrombasthenia now. I don't know why I can't say anything properly today. We get these two things, right? Okay, cool. Now the next one is something called von Willebrand disease. And actually, this is probably the highest yield thing, like disease on this slide, all right? What's super unique about von Willebrand disease is that you know how we said these two diseases are a defect in primary hemostasis? Von Willebrand disease is a defect in primary hemostasis and a defect in secondary hemostasis, which means that there is an issue with both. And let me tell you the reason for this. Von Willebrand factor, kind of common pathway. Von Willebrand factor is the only factor that is actually involved in both primary hemostasis and secondary hemostasis. Its involvement in primary hemostasis is that Oh no, I spoiled it. Its involvement in primary hemostasis is that it acts as a place for platelets to adhere. Its involvement in secondary hemostasis is that von Willebrand factor is responsible for carrying factor 8. And factor 8 is something that is present in the intrinsic pathway. And we're going to talk about all of those pathways in a bit. So von Willebrand factor, if deficient, means that there is an issue in both primary hemostasis and secondary hemostasis. And that's super high yield, all right? You need to understand that von Willebrand factor is the only thing where it's an issue in both, or the only disease in this slide where it's an issue in both, because it carries factor 8. And you always need to remember that von Willebrand factor carries factor 8. And the reason it's so high yield is that von Willebrand disease is the most common disease from these that people have. So we understand Bernard Soliere, Glanzmann thrombasthenia, and von Willebrand disease now. Yes, yes. Okay, awesome. Cool. I'm glad. So make sure you guys understand those diseases well, because they're a very easy thing to get an MCQ on. Like they can say, no, this person has this deficiency. What disease is it? Like that's it can be that simple. It can be a little more complicated, but make sure you understand these diseases well. Okay, let's talk about the pathways. All right, this is a heavy slide. It's complicated. You don't need to know everything on here. You really don't need to know everything on here, okay? I'm going to tell you what you guys do need to know. First of all, there are 3 pathways that go into the clotting cascade of secondary hemostasis. The end goal of secondary hemostasis, which we said, is to form a fibrin plug. All right. Now we have all of these factors in our body, right? And it goes from 1 to 13 in Roman numerals that are all made by our liver. Okay. Our liver makes all of these clotting factors. Now we have the intrinsic pathway and the extrinsic pathway. Here's the easy thing. The extrinsic pathway only has one one clotting factor. And here, just to make you guys understand it a little better, the extrinsic pathway is usually triggered by an external injury. So like, for example, a cut or something. The intrinsic pathway, however, is something that's sort of always being activated in our body and then inactivated and activated and inactivated, because our body has to have that constant balance of it's like a scale of like, are we bleeding, are we not bleeding, are we bleeding, are we not bleeding? So that's why intrinsic is called intrinsic, because it's mostly like it's always going on. Extrinsic is usually triggered by something external. Anyways, the way to remember the extrinsic pathway, or the way that I remember it, is I don't know if you guys know who this is. This is Cloud Strife. He's from a video game called Final Fantasy VII. And I don't know, in my head, the way I remembered it in first year is that a lot of this game to me took place outdoors, and its entire theme is about like pollution and blah blah blah. So that kind of equals extrinsic to me. So 7, Final Fantasy VII, that's how I remembered it. You can make up any mnemonic you want. All right. 3 plus 7. Whatever you want to do, you guys can do. That's the extrinsic pathway. And the extrinsic pathway is measured, or the lab test that we do to measure how it's functioning is something called PT. And we're going to talk about it, and I'm going to give you guys a mnemonic for it. Now for the intrinsic pathway, there's a lot of factors in here. And truly, you don't need to remember all of them, nor do you need to remember these names. It's rarely anybody uses these names. We just call them by their number. Really, all we want to do is have both pathways activated, and then that way we're able, do we remember to remember the names for the factors? Most likely no. I honestly didn't learn them in first year, and it didn't. Yeah, tissue factor is important. Fibrin, fibrinogen, those. Most of the time they go by the number of the factor. Okay. Back to what I was saying. Yeah. So extrinsic and intrinsic pathway come together, and they activate factor 10 to factor 10A, and that cascade keeps going until we convert fibrinogen to fibrin, and then we have the clot. As for factor 13, which is over here, the job of factor 13 is to take the fibrin plug that was made and cross-link it to make it stronger. So factor 13 is here to make the fibrin plug a lot. To make the fibrin plug stronger so that the bleeding actually stops before the fibrin plug is dissolved. All right. Now, again, we know that von Willebrand factor carries factor 8. I just want to make sure that that was clear. We talked about the phospholipid surface, which is a requirement. You can see in the phospholipid surface is needed in a couple of places for this clotting cascade to happen. And calcium is entirely necessary. We need calcium in order to do this, all right? And calcium, its sources are from platelets and from the plasma. When platelets are degranulating, one of the things that they release, among many other things, is calcium, all right? So what do you need for the clotting cascade to work? You need tissue factor. You need the extrinsic and the intrinsic pathway both working. You need a phospholipid surface from the platelets, and you need calcium. And then you're going to form fibrin. Now this over here, this math is how I used to remember the common pathway, because the factors involved in the common pathway are factor 1, factor 2, factor 5, and factor 10. So 1 times 2 times 5 equals 10. That's how I remembered the factors in the common pathway. Factor 13 is not really considered part of the common pathway because its job is after the fibrin plug is formed, and it's just strengthening the fibrin plug. So does everybody understand this? This is, you need to understand this to understand what are the extrinsic and the intrinsic pathways. Okay, so the extrinsic and the intrinsic pathways are both two pathways that are needed to happen in order to form a fibrin plug for secondary hemostasis. All right, so the extrinsic pathway needs tissue factor in order to be triggered, all right? And the extrinsic pathway, can you explain it in short? Okay, let me finish this and then I'll explain it in short. The extrinsic pathway usually needs an external injury to the tissue or to the vessel to release tissue factor to activate factor 7. The intrinsic pathway is kind of always being activated and inactivated in our body. That's why the names are like that. They come together, they activate factor 10, and then they keep going until they form fibrin. In short, for Ura, extrinsic pathway, intrinsic pathway both get activated when there's bleeding that needs to be stopped. They converge at the common pathway and they form a fibrin plug. The factor that's necessary in the extrinsic pathway is factor 7. That's the only factor in the extrinsic pathway. The factors of the common pathway are factors 1, 2, 5, and 10. 1 times 2 times 5 equals 10. All right? You don't need to remember the numbers of the intrinsic pathway because you know the numbers of both other pathways. So you can figure that out by, exclusion. The requirements for both of these cascades to work is a phospholipid surface and calcium. That's it in short, as short as it can be. All right. Everyone understood this. I will not move on until everyone has said that they understand this. Cool. Yes. Understood. Awesome. Can you repeat? Of course. So there are two pathways that are needed for secondary hemostasis to happen so that we can form the fibrin plug. There's this extrinsic pathway and there's this intrinsic pathway. Okay. They are made up of factors that come from our liver. Factors are like sort of things that the livers produce, proteins that the livers produce to stop bleeding. Okay, so we have factor 7 and the extrinsic pathway, a bunch of other factors in the intrinsic pathway, and then in the common pathway, we have 1, 2, 5, and 10. Both of these pathways come together, right? They both get activated and they keep activating each other until you reach factor 10. At factor 10, it gets activated, it continues the common pathway until you form a fibrin plug. All right? After that fibrin plug is formed, factor 13 is going to come and it's going to make the fibrin plug stronger. Is that clear? Can you explain the blue boxes thrombin? Okay, yeah, you don't really need to know this, but basically thrombin, which is factor 2 actually, or activated factor 2, is needed for a lot of other, it's just needed in order to activate a lot of other factors. So thrombin is needed here, it's needed here, it's needed here. You don't really need to know that thrombin is needed to activate factor 11 to 11A. But this, again, like I said, a lot of hematological diagrams, especially for the clotting cascade, are pretty complicated. But at your level, just understanding what the clotting cascade is and what the factors are is more than enough, because there's a lot that goes into the activation of a bunch of factors. Where is factor 1? Fibrinogen is factor 1. Hold on, let me clear the slides because it's right here. Fibrinogen is factor 1. Activated fibrinogen is factor 1A. So the factors we need to know are 1, 2, 5, 7, 10. Yeah, I guess 13 as well, because 13 is what's needed to strengthen the fibrin plug. Just know that factor 7 is in the extrinsic pathway. 1, 2, 5, 10 are the common pathway. Factor 13 strengthens the fibrin plug. Any other questions about the clotting cascade before we move on? This is one of the highest yield things in this lecture. So make sure you understand this so that you're able to understand everything else. Understood? Awesome. I'm going to move on. If anyone has any questions, I'll answer them as I'm going. So here's a mnemonic for the tests that are used to check each pathway. All right. So there is something called PT, prothrombin time, and APTT, which is like activated partial prothrombin time. All right. PT, or the way we like to call it, play tennis. Can you repeat the role of calcium in the pathways? All you need to know is that calcium is necessary in order for the clotting cascade to work. So you cannot, if you don't have calcium in your body, you can't stop bleeding. You can't do secondary hemostasis. All right. Hasna, did you get that? Oh, maybe I shouldn't. Never mind. Yeah, okay. So the mnemonic that I want to give you, PT, or play tennis, you play tennis outdoors. And so PT checks the extrinsic pathway, because extrinsic kind of means outdoors. Not at all, like definition wise, but the word extrinsic you associate with outside, external, blah, blah, blah. So you guys got that? PT, play tennis, you play tennis outside. PT is for the extrinsic pathway. Okay. Now, there is one drug that will extend PT that you guys should know at your level, and it's called warfarin. And the reason I capitalize the war is because wars are fought outside. So warfarin can extend PT. All right. APTT is play table tennis. And you play table tennis inside. So it's for the intrinsic pathway. All right. And there is a drug called heparin, which can extend APTT. So do you guys get this mnemonic? Because you never want to be mixing up PT and APTT. It's amazing. Thank you. I didn't come up with it. It's just what I found somewhere when I was in first year. But I learned it in first year and I still use it up till now in fourth year. What does extend mean? All right. So yeah, sorry for not explaining that. PT and APTT are in a time. All right. So it's actually like the number of seconds that it's. So for example, for PT, it's kind of like the number of seconds it takes for the extrinsic pathway to work. All right, and form a fibrin clot. Do you get what I mean? So if the time is longer than normal, that means that there's an issue with the extrinsic pathway. If the time here in APTT is longer than normal, it means there's an intrinsic pathway. There is an issue with the intrinsic pathway. Clear? Clear. Awesome. Moving along. All right, now this next part of the lecture is pretty easy. It's just some general stuff that we just need to talk about quickly. One of the some of the hardest thing ever, not hard, one of the hardest parts of this lecture is done, and you guys got it. Good job. So what causes bleeding? We already talked about it, is any injury to the vessels. If there's an issue with the vascular integrity, you're gonna have bleeding. If you have thrombocytopenia, which is a really big word that hematologists use, that just means low platelet count. If you have thrombocytopenia, then you're going to have an issue with bleeding because you don't have the platelets there to stop bleeding. Or if your platelets are not functioning properly, you're going to have an issue stopping bleeding. Lastly, if you have deficiency or a defect in any of the clotting factors, 1 to 13, you're going to have bleeding. All right? So what are some common presentations that you will see in a patient that is bleeding? And I know you might think like, oh, blood. Not necessarily. There are certain sort of scenarios where you can begin to think, oh, this person might have a blood disorder. So if they have spontaneous bruising or very easy bruising, that can indicate a bleeding disorder. If they're constantly having mucosal bleeds, which kind of just like, for example, nosebleeds, that could indicate bleeding disorder. Actually, fun little question for you guys. I wrote noseblood. Fun little question for you guys. What is the medical term for nosebleed? Does anyone know? Epistaxis. Yeah. Good job. I didn't know that at this point. If you have prolonged bleeding, pre-med, I wish I was there. If you have prolonged bleeding following any cuts or incisions, might indicate a thing. And a very, very common sort of question scenario that you'll get is a baby that is born that gets a circumcision has prolonged bleeding following the circumcision. All right. If they say, you know, this person had prolonged bleeding following circumcision, it's likely that they have a bleeding disorder. Another thing is called hematoma, which just means a collection of blood in a space. All right. Or hemarthrosis, which means the collection of blood in a joint or a cavity. Okay. And last but not least is in a intracranial, which means in the head, or intra-abdominal bleeds. What's hematoma? A hematoma is the collection of blood in a body cavity. So for example, like it could be anywhere. Like you could have a hematoma happen anywhere, honestly. It's just a collection of blood in a body cavity, but hemarthrosis is the collection of blood in a joint. So a very common place that people get hemarthrosis is in their knee. So they'll have a lot of collection of blood in their knee area. We all get this, the common presentations. It's important that you guys get this just because a lot of questions are going to lead with like, this patient does it not relate to sickle cell? It can, but hematomas can happen from a lot of things. Surgery can cause a hematoma. Maybe if you just, a lot of things can cause a hematoma. It can happen in sickle cell too. Like anything can really cause the collection of blood in a space or in a cavity. So yeah, as I was saying, it's important that you guys understand the common presentations in a bleeding patient, just because a lot of questions that you'll get will sort of lead with this. They're not going to be like, this patient has a bleeding disorder. They're going to be like, a 3-month-old boy came to you and he has a history of prolonged bleeding post-circumcision. All right. Moving on. You're going to want to know the onset of the bleeding. So was it hereditary? Was it inherited? So if a patient have those, what does it tell us? If a patient has one of those things that I just talked about, It doesn't guarantee that they have a bleeding disorder or an issue with their secondary or primary hemostasis, but it should make you start thinking, okay, this person probably has an issue with their bleeding and their clotting cascade and stopping bleeding. All right. Okay. So you need to know the onset of bleeding. So hereditary is like, was it inherited? So common presentations of like an inherited bleeding disorder would be epistaxis, which is nosebleed, or post-circumcision bleeding, prolonged post-circumcision bleeding, or a bleeding disorder could be acquired, which just means that you get it at some point in your life. Things happen. Now, for the types of bleed, this is like a little life hack. If the type of bleed is mucocutaneous, which means it's more superficial on your body, it's likely that the bleeding isn't due to an issue with your platelets. So we talked about the Glanzmann thrombasthenia and the Bernard Soliere. But if the bleeding is within a cavity or much deeper in your body, it's likely that the issue is actually with the clotting factors. So do we get that? Yes, awesome. So we need to know the severity of the bleed. Does it start happening super severely, spontaneously, and it just happens كذا فجأة? Or is it happening when you're actually performing blood tests on the patients and actually sort of pushing the patient's body to bleed so that you can see what's going on? You want to know how frequent the bleeding is because what did I say? Oh, in Arabic, I'm sorry. Suddenly, like unprovoked, spontaneously, just like if their bleeding starts suddenly. The frequency of bleed you want to know because you just want to know how often is this person bleeding, how much blood are they losing, and the timing of the bleed. Is the timing of the bleed immediately after the injury happens, or is the timing of the bleed, and this is very important, delayed? If the timing and what wait, let me just explain what I mean by delayed. What I mean by delayed is that if a person gets an injury, right? If their bleeding is delayed, what this means is that the bleeding stops, right? And then after a little bit, it starts to bleed again. Okay. And what this indicates is a factor 13 issue. Can anyone remind me what factor 13 does? Stabilize, strengthens fibrin. Exactly, Saad. Factor 13's job is to stabilize fibrin. Yes. So it's not stabilizing the platelets, it's not activating factor 10. It's making sure that the fibrin clot that's formed is stronger. Okay. So if you have an issue with factor 13, that means, yeah, I'm going to go back and show you guys this picture. So if you have an issue with factor 13, it means, yeah, the fibrin clot is getting formed. And here it is, it's there. But factor 13 acts on the fibrin clot after it's formed, right? So if you have an issue with factor 13, that means you are not getting this stronger cross-linked fibrin, however it's pronounced, which means that when you stop the bleeding, it's going to dissolve quickly and you're going to start bleeding again. Is that clear? Yep, awesome. So make sure you understand that if they ever say like, oh, this person is having delayed bleeding, a light should go off on your head and think, okay, maybe this is the factor 13 issue. Okay? Yay, we got it. Moving on. Here, we're just going to go over some, we're going to put pictures to what we just talked about. All right. So here, this is what a cutaneous bleed looks like. So this is likely due to a platelet issue, right? You can see this is all little bleeds going on, like all over. I don't know why I'm circling. It's all over the leg. Those are all little bleeds going on, and it's likely due to a platelet issue in this person. All right. Here is a mucosal bleed. That's again epistaxis. That's you guys know what a nosebleed is. This is bruising. You guys know what bruising is. And this is hemarthrosis. You can see in both knees actually, this patient is having blood being collected inside the joint of their knee. All right. We got all the pictures. We understand those things. Yes, yes. Bruising and hemarthrosis. What about them? Does she have both? She does have both, yeah. She has bruising here and she has hemarthrosis. So there's a blood disorder here. Good catch. All right, now let's talk about the lab tests. This is the second very high yield part of this lecture because you really need to understand the lab test that you're going to do to check for bleeding disorders, because a lot of the questions that you're going to get in the exam are going to give you the lab tests, and you have to know that they're abnormal and know what does it mean if those lab tests are abnormal. Okay. Did you add the clinical details on your own? I don't see it on the professor's slide. Oh, huh. This is my slides, or this is, oh, it's on Sunday. I don't know. These are slides from last year because I didn't get your guys's current slides. But okay, so you guys didn't take this lecture yet. So you're gonna go knowing stuff. Anyways, it's usually the same lecture every year. Like I don't think this lecture hasn't changed since I was in first year. So there is some stuff not there. You'll get an updated version on Sunday when you take the lecture. And if you have any questions then, my phone number is at the end of the presentation that you guys can take and ask me any questions about the lecture. If there's anything I didn't cover. All right. So back to the lab tests. You need to understand the lab test well because a lot of the questions are going to be an abnormal lab test, and you have to understand what does that mean, what does it indicate. Here are just some general things that you guys need to make sure of before doing a lab test or a blood lab test on any of these patients. You have to make sure they didn't get any recent transfusions of blood, of plasma products, of platelets, of anything, because they just got transfused. That means that their lab test is not going to come out correct because they just got new, fresh stuff from another location, all right, or another person. And you have to make sure the patient is not on certain drugs. For example, aspirin, NSAIDs, and antibiotics. And I want to take a second here to talk about aspirin. All right. Aspirin is another drug that's pretty high yield for you guys just right now. And you all know aspirin, the painkiller, right? So aspirin actually also acts as a blood thinner. All right. And the reason it does that is it inhibits thromboxane A2. And does anyone remember what thromboxane A2 does and where it's from, what it's released from? Endothelium? No. Released from platelets, attracts platelets. Exactly. Uh, hello, I hope you understood and know it's released from platelets and it attracts platelets. So thromboxane A2 is needed to form the primary hemostasis. It's needed to form the platelet plug. All right. So if that's being inhibited, that's going to cause, again, an abnormal lab test. So you have to make sure the patient hasn't been on any of these because these are going to cause an abnormal lab test. And you might start to think, oh no, they have a bleeding disorder. We need to go do something about it. But in reality, it's just because they're taking aspirin. Okay. So just remember that one of the things that aspirin can do is inhibit thromboxane A2. Because sometimes you'll get a question where they'll casually, nonchalantly mention that the patient is taking aspirin. And you need to be able to be like, oh, okay, I know that they're taking aspirin, which means that that inhibits thromboxane A2, which means that they might have a problem with primary hemostasis. All right. So you guys got the aspirin thing. I know that the drug stuff is kind of confusing in first year, but I want to make sure you guys understand these things. You don't learn money drugs in first year, but there are some that you have to know. We understand aspirin. I'm waiting for yeses in the chat. Okay, there we go. One yes. Yes, 2 yeses. Thank you. Aspirin makes blood more water-like. Yeah, you can kind of think of it like that. I don't know if that's like actually medically correct, but to be honest, I kind of think of it in the same way. It just makes blood, you're less likely to, you're gonna have an issue with clotting if you take aspirin. Okay. But hella, don't like, I don't know if that's super medically correct. I tend to think of a lot of things in a very simple, childish way, but I also think of aspirin as doing that. And if that helps you understand it, by all means do that. Moving on, here are the first line tests for hemostasis. Okay. Now the first line tests, they are easy to perform. They're simple. They're quick. You can get these done like this in the clinic. Okay. They're very fast. All right. And once you have an abnormal first line test, you're gonna know, okay, what's the next test I have to do? Because every test you have an idea of, okay, what's the next, you start taking a step in the right direction towards the correct diagnosis. Okay. So here are some of the screening tests we're gonna go over. Let me clear this because I drew by accident. So the platelet count and the morphology, right? The bleeding time, which is literally just how long the patient bleeds for, or PFA 100, which is platelet function analysis or analyzer 100. It's a machine. We're going to see it in a bit. Prothrombin time, which we talked about, PT. What does prothrombin time check for? Which pathway? I'm doing a little drum roll. Extrinsic, perfect. And then APTT, which is activated partial thromboplastin time. What does that check for? Perfect. Okay. And then you can just check for factor 13 by itself because we said it's really not in any of the pathways. Okay. So first, let's talk about platelets. All right. The main characters of this entire thing. Okay. One of the main characters. The cast is huge for hemostasis. So we want to check the platelet count and we want to check the platelet function. And the way that we can check the platelet function is bleeding time or PFA 100. Bleeding time, if everything is normal, but there's bleeding, does that mean we have a problem in factor 13? There's a lot of things it could be. Like if there's a chance that a lot of things are normal, but there's still an issue. For example, in von Willebrand disease, and this is definitely too high for your level, but in von Willebrand disease, a lot of things like it could be all normal. But the main idea that you want to have for factor 13 is that if there is a delay in bleeding, that's when you should think that there's an issue with factor 13, which means if there is the bleeding starts, stops, and then starts again later, that's when you think factor 13. Anyways, for platelets, you want to assess their function and you want to check their count. So I have some pictures here. This person, but doesn't a delay in bleeding also mean disorder and primary hemostasis? Not necessarily, because primary hemostasis is just, again, forming that platelet plug. And usually that platelet plug, if there's an issue with primary hemostasis, the bleeding is not going to stop initially. What's unique about the factor 13 issue is that the bleeding stops, which means you went all the way to forming the fibrin plug, and then the bleeding started again, which because that fibrin plug was not strengthened by factor 13. If you have an issue with primary hemostasis, you're probably not going to stop the bleeding to begin with. Okay. So this is just a slide that Dr. Rehan put because this person, they got a low platelet count, and then they were like, why does this person have a low platelet count? They seem to be normal. So they went and they actually looked at they did a smear and they looked at it. And the reason the platelet count was abnormal is because the platelets were clumping together. And when they clump together, they get counted as less. So this gave a low platelet count. So I guess this slide was sort of put here so that you guys can know that even if the test does come out wrong, this is like in real life. It doesn't necessarily mean that something is wrong. All right. Next, giant platelets. Okay. So here are the platelets. All right. These, you guys know that these are all RBCs. Like giant platelets actually is seen in Bernard-Soliere syndrome, and nobody really knows why, but it's just a thing that's present in Bernard-Soliere syndrome, is that they have giant platelets. That's, again, I guess, a fun fact for you guys. Helps you remember Bernard-Soliere a little better. Oh, okay, so now let's talk about how do you know if they're platelets or lymphocytes? Platelets are always gonna be really tiny. Oh my God, I'm messing up the slide. Platelets are always gonna be really tiny. So you see how like this right here, that's a platelet. All right. Platelets are little tiny purple dots. Okay. These are lymphocytes. You can see their nucleus. You can see, yeah, those are like these are, sorry, what this is showing is the platelets. So hold on, let me clear it to make it, oof. Let me make it a little more clear for you. These are the platelets. Like, do you see that? These are the platelets. These are the platelets. They're coming, other picture. Here, there's no nucleus here. Like, you don't see a clear nucleus here. But also, you're most likely not going to get a picture like this in your exam. This is the Bernard-Soliere one. Bernard-Soliere is a deficiency in GP1B, which is needed for platelet adhesion. We get this one. We get this. We got these. Just pictures, the lymphocytes, stuff like that. Let's talk about bleeding time. So here is a really old way of how they used to check bleeding time. They don't really do this anymore. But what they used to do is make like a little cut in the patient, and then they had this paper, this like lancet paper, and they would tap it on the blood and then keep rotating it and keep doing it until no more blood got on the paper. And then they would they would take the time of how many minutes it was for that bleeding to stop. So normally it's between 2 to 6 minutes. What you need to know though is that checking the bleeding time is you checking the platelet function. Okay? Because again, that first step is forming that platelet plug, which is going to initially stop the bleeding. All right. This is the platelet function analyzer 100. There's a lot of words on the slide that you can read on your own time if you guys want to. This is more for your interest. This is what the machine looks like. This is what they do use now these days. And it just tests the platelet function. That's it. It's a slide that you can honestly skip if you want to. But if you're interested in like the details of it, it's here. So what are causes of prolonged bleeding? Again, thrombocytopenia, low platelets, a functional disorder that's inherited, or a defect that's acquired. Simply. Moving on. We need to look for issues in secondary hemostasis as well. We can't just look at the platelets, right? And then be like, okay, we saw the platelets. No, we have to look at the second part of this entire thing, which is the clotting cascade, right? So these tests that look for issues in secondary hemostasis are basically just testing the time it takes to form a fibrin clot, okay? And that's how they carry out these tests. This text on the bottom is sort of details of how they do it, but they take these samples and these blood samples that are anticoagulated, which just means that they're not going to clot while in the tube. And then they trigger the coagulation cascade, or they trigger the clotting factors to start doing their thing, because by adding calcium and by adding another activating agent, which you don't really need to know, and they count the time of how long it takes for a clot to be formed. So that's how we test for that's the idea of how we test for secondary hemostasis. We're going to get into the actual tests in a bit. But do you guys understand the idea of what they're looking for? Yep. Just want to go back because I think this would be, I don't know, I think this would be a good way to test you guys. But maybe it's a little hard. Can you guys give me something that would cause an inherited platelet function disorder and something that would cause an acquired platelet function disorder? We talked about all things that could, we talked about one acquired and two inherited, at least. So I want one of each. And it's hard, I know, but it's, using your brain is what's going to make you remember it on the exam. So inherited is GP1B, correct? Do you remember the name of the GP1B deficiency? And you can spell it wrong because I don't know how to spell it either. D, Bernard, yes. Bernard Soliere. So that's an inherited platelet function disorder. What is a way to have an acquired platelet function disorder? So the second one is Glanzmann's. Yeah, that's the inherited. But what is an acquired platelet function disorder? VMF? No, that is another one that is inherited. And that's again for von Willebrand factor is the one for and primary and secondary hemostasis. Think about it. Think about it. What's something you guys take when you have a headache that might inhibit a certain thing? Yeah, there we go. It might inhibit a certain thing. What does aspirin inhibit again? There we go. Yeah. So taking thromboxane taking aspirin can inhibit thromboxane A2, and that can be an acquired defect. So aspirin. So that just helps to sort of, separate things in your mind of like what's inherited, what's acquired, what does that mean? And yeah. So the people who said thrombin, it's thromboxane, which is released from thromboxane A2 specifically. So I'll write it here. Thromboxane A2. That's what aspirin inhibits. Right. So the end point of each of these tests that we do to check for secondary hemostasis is that we want to see the formation of fibrin, period. We want to see the formation of fibrin. And what you guys need to know, and I put it in red and bold, so you guys need to know it, is that none of these tests measure factor 13. Because remember that factor 13, which is over here, doesn't act until the fibrin clot is formed. And all of the tests that we're about to talk about test up until here, and they do not test this part. Okay? So remember that none of these tests are testing for factor 13. Okay? Now, if you are going to remember anything from this lecture, you remember this slide, because this slide is basically going to be all of the questions in the exam regarding this lecture. Okay? This slide, I will spend an hour on the slide if you guys need it. I cannot emphasize how important the slide is. Okay? Here are 3 key scenarios that you're going to need to know for basically anything in regarding the next couple of slides. So if only PT is prolonged, and remember, PT is extrinsic pathway. If only the PT is prolonged, there are 2 possibilities. All right? Either this patient has a factor 7 deficiency, or this patient is on warfarin. If the only thing that is prolonged and abnormal in this patient's tests is PT, these are the only 2 possibilities that this patient may have. All right? Either their factor 7 is deficient or they're on warfarin. If only their APTT is increased. Because remember, why not other factors? Remember that PT is checking for the extrinsic pathway. All right? What's in the extrinsic pathway? Factor 7. Well, PT and APTT are checking the extrinsic factor, or sorry, extrinsic pathway, and they both also check the common pathway. But again, if only PT is prolonged, then that means only factor 7, there's an issue with it. What does warfarin do? Warfarin is an anticoagulant. I'm not going to get into the mechanism of action and stuff just because it's too advanced for your guys' level. But all you need to know is that if in the question they say, Sidra, I'll get to your question in a bit. But if in the question they say the patient is on warfarin, think that their PT should be prolonged. The mechanism of action of warfarin and stuff you're going to talk about in third year when you take Hem-Onc again. What about tissue factor? What about tissue factor? Let me see where maybe your confusion is coming from. Let me just check. So why do you think tissue factor? Oh, because tissue factor is needed to activate extrinsic pathway. Is that what you mean? Tissue factor is not a clotting factor. And these are only checking the clotting factors, right? So for PT, don't think about tissue factor, just think about factor 7, all right? Now, the next key scenario, if only APTT is increased, all right? And this is checking the intrinsic pathway. That means any of the clotting factors in the intrinsic pathway could be, there could be a deficiency or a defect in them. Most commonly, it is factor 8, all right, in males, usually. And we're going to talk about a disease. If the patient is a female, it's most likely going to be factor 11. And we'll talk about why that is. Rarely do you ever have factor 12 deficiency, all right? Because nobody, if I recall correctly, nobody really knows what factor 12 does. And there are some people with defective factor 12 and it doesn't really affect. Anyways, that's just like research stuff. But what you take away from here is that if only APTT is increased, if it's a male, it's most likely factor 8, second most likely factor 9. If it's a female, it's most likely going to be factor 11, or the patient's on heparin. All right? We get the only APTT increased. We understand that, صح? All right. Now, in a scenario where both are increased, okay, that means that there is an issue with the common pathway. Why is that? This is because, remember, the way these tests are being held out is that we're putting something in a blood sample and we're trying to get a fibrin clot formed, which means that both PT and APTT are technically also testing the common pathway, right? But if only one of them is elevated and the other one is normal, that means that it's for the specific factors in either the extrinsic or intrinsic pathway. However, if both are elevated, that means that there's an issue with the common pathway because both are also testing the common pathway. Okay? So if both are elevated, that means you have an issue with factor 1, factor 2, factor 5, or factor 10. Any of those could be true. All right? Or you're going to have a vitamin K deficiency. Now, this is not really going to be talked about, I think, in first year, but I feel like it's important to talk about. Vitamin K is necessary for a lot of the clotting factors, okay? Because vitamin K acts as a cofactor and is basically needed for these clotting factors to work. You don't need to remember exactly which ones they are, but I'll tell you them in case you're curious. Factors 2, factor 7, factor 9, and factor 10 are the vitamin K dependent cofactors, all right? And as you can see, factor 2 is in the common pathway. Factor 7 is in the extrinsic pathway. Factor 9 is in the intrinsic pathway. Factor 10 is in the common pathway. So you're going to expect that both will be increased if you have a vitamin K deficiency, okay? Now, I guess another fun fact for you guys to help solidify it more is that because of this, A lot of the time when newborns are first born, they'll inject them with vitamin K, like almost immediately so that the baby doesn't bleed. Okay. The next thing that could cause both PT and APTT to be increased is liver failure. Can somebody tell me why liver failure might cause both to be increased? Liver releases, liver makes platelets, liver releases the clotting factors, producing the factors. Yeah. All right. So yeah, liver doesn't make platelets. The liver, the bone marrow makes platelets. You will talk about it. It was in the picture. Yes. Was it in the? Yeah, it was in the picture. I put a picture of the liver. The liver is responsible for making all the clotting factors. So if you have an issue with the liver, you have an issue with all the clotting factors, both PT and APTT are going to be increased. All right. The last thing is um, something called DIC, which stands for disseminated intravascular coagulation. Liver makes thrombopoietin, which decreases. Thrombopoietin is needed, I believe, to make platelets. Yeah. So but yeah, okay. I see your thinking here. If there's liver failure, a lot is going to go wrong in the body. But what you need to understand from the slide is that if there's liver failure, both PT and APTT are going to be increased. Okay. On to DIC. DIC is something you're going to take in detail in second year, but think of DIC as the ultimate failure of hemostasis. It stands for disseminated intravascular coagulation. And it's one of the worst things that could happen to a person. Essentially, remembering just DIC is enough, right? Yeah. Also, I highly doubt you guys are going to get asked anything about DIC, but just for the sake of completion, it's included in the slide so you know that both are increased. But what happens in DIC very briefly is just picture that all the clotting factors in your body get activated and they make clots, and then all of them are lysed, and that keeps happening. So you're just using up all the clotting factors in your body faster than the liver can make them. So if they have DIC, it's going to increase both PT and APTT. Also, I just realized I wrote intric here. So do we understand this slide? I promise you that I like your explanation. Thank you. I promise you that this slide, if you take away nothing from this lecture, if you study the slide alone, you'll be able to at least answer like half of the questions regarding hemostasis. More than half, actually. Like this slide is, I can't emphasize how important it is. All right. So make sure if you guys don't understand the slide, when you say increased, do you mean the blood won't stop? Increase. No, by increase, I mean the time of the test. So PT, APTT are both measuring the time it takes for a clot to be formed. So that's done in seconds. I don't remember off the top of my head what's the normal range is, but like they will give you in the exam the normal range, and then they'll give you how much the patient had. So they'll say, for example, the patient's PT was 35 seconds and the normal range is 10 to 15. So now you know, okay, this person's PT is increased, which means that they either have factor 7 deficiency or they're on warfarin. Okay. What was warfarin again? Warfarin is an anticoagulant drug that's used for a lot of things. Um, and what you just need to know is that warfarin will increase PT and heparin will increase APTT. That's all you need to know for this exam. What is the main factor for the intrinsic pathway? There is no main factor for the intrinsic pathway. The intrinsic pathway is made out of factors 8, 9, 11, and 12. Now, those are all the factors that play part in the intrinsic pathway. But in terms of this, factor 8 is most likely to be deficient in males. Factor 11 is most likely to be deficient in females. Any other questions regarding the slide? No. Awesome. Moving on. So this is sort of a repetition of everything I just said. All right. So PT, oh, by the way, INR stands for like institutional. Actually, let me Google it right now because I don't remember. International something ratio. Oh my God, I look so unprofessional right now. International normalized ratio. Okay. Ugh, that was embarrassing. So international normalized ratio, basically all that means is that every hospital in the world was like, hey, we all have different times for PT. Let's convert all our PT times to an international ratio so that we all are on the same page. Uh, just say they're just gonna have sometimes INR after PT. It's the same thing. All right. PT INR measures the extrinsic pathways and it measures the common pathway. So that means 1, 2, 5, 10 for the common pathway and 7 for the extrinsic pathway. All right. APTT, we said measures the intrinsic and the common pathway. So again, that's 1, 2, 5, 10 for the common pathway, 8, 9, 11, 12. No, 8, 9, 11, 12, yeah, for the intrinsic pathway. That's it. If you just remember what's in the extrinsic pathway and what's in the common pathway, you can by deduction remember what's in the intrinsic pathway. Now, just some quick, like a little bit of a high yield thing. There are some X-linked diseases, and you guys understand what X-linked means, right? Or have you not taken genetics yet? Said no. We might not have. Okay, no sex. So yeah, it's a sex chromosome. So you know how people are either XX or XY if they're female or male. So an X-linked disorder just means that the actual like gene for the disease is on this X chromosome. Okay. And hemophilia, right, is an X-linked disorder. I'm going to change the color of this thing so you can see. So all that means is that because males are XY, males are much more likely to be affected by hemophilia because they only have one X. Females have two X's, which means the other X, which doesn't have hemophilia, will compensate and they won't like actually express the disease. They won't have it. They'll carry it, but they won't have it. So do you guys understand what like X-linked disorder means in this context and why hemophilia is mostly in males? Okay, yeah. So there are two hemophilias. Hemophilia A is the most common and it's a factor 8 deficiency. That's why I said in that previous slide that factor 8 deficiency is the most common in males, right? Hemophilia B is a factor 9 deficiency. Really, all you need to know is that hemophilia A is factor 8, hemophilia B is factor 9. It's an X-linked disorder. It mostly affects males. Hemophilia A is the most common. Those are what you need to understand from this. So we got it. We understand hemophilias. So for that reason, it's unlikely that a female would have a factor 8 or a factor 9 deficiency. Factor 8 or a factor 9 deficiency because these are usually X-linked disorders that are seen mostly in men. All right. Okay, we got it. I'm moving on. Again, here's another slide that's more for your guys' understanding and less for the exam and memorization. But to do a PT INR, you take the patient's plasma and you remove the calcium from it. And then you add something called thromboplastin, which is basically a phospholipid and tissue factor. And then you add calcium again. And then this is going to activate the extrinsic pathway because remember, you need tissue factor to activate the extrinsic pathway. And then you just take the time in seconds until fibrin is made. That's how you do PT-INR. All right. So PT-INR, this is, again, the scenarios that I mentioned. This is just more repetition. It monitors patients on warfarin. all right? And it's in a factor 7 deficiency. Here he says that it also can look at in liver failure, but remember all clotting factors or coagulation factors will decline. The patients in DIC who are using up all of their clotting factors, and before any surgery, you're going to want to take these and you're going to want to check these because you don't want the patient to bleed during surgery. But for the sake of your guys' exam, I advise that you check that slide that I made and use that. To do APTT, for the intrinsic pathway, you take the patient's plasma, you remove calcium, and then you just add a phospholipid and calcium. So in APTT, you're not adding the tissue factor because you don't need tissue factor to activate the intrinsic pathway. APTT, like we said, is used to monitor patients on heparin. It checks for factor 8 and factor 9 deficiency mostly because those are the most common usually. But it also might be elevated in some cases of von Willebrand disease or von Willebrand deficiency. Why might it be elevated in von Willebrand deficiency? Come on, think. Why would APTT be elevated in von Willebrand deficiency? Try to remember, what does von Willebrand do? Why is von Willebrand disease also considered a secondary hemostasis disease? Should I help you guys? Should I cheat you guys out? Should I tell you? Do you want to think? You want a hint? I gave you a hint. The hint is that it has GP2B3A. Von Willebrand doesn't have GP2B3A, but it does carry something that makes it. That's why it is considered also a secondary hemostatic disease. It helps in adhesion with GP1A. Correct, but that's not why it might elevate APTT. Should I do this and then do that? Does that help you guys? It's the ugliest arrow I've ever drawn here. That's, yes, von Willebrand factor carries factor 8. So if there's an issue with von Willebrand, it might, or if there's a deficiency in von Willebrand or an issue with von Willebrand, it might not be carrying factor 8, which means that the intrinsic pathway can't do everything that it should be doing, which means that APTT may be increased. We get it? You understand? You should remember that von Willebrand factor carries factor 8, and it also binds to GP1B. It has 2 jobs. All right. So again, APTT also evaluate patients in liver failure where all their coagulation factors would be decreased, patients in DIC who are using up all their coagulation factors, and before surgery. Same as the other thing. Factor 13. I'll buy, whoever can tell me what game this character is from, I'll buy them a cookie on post foundation final exam. Don't search it. Not Final Fantasy VII. Same company though. So let's talk about factor 13 a bit. It's not Genshin. I don't play Genshin. Let's talk about factor 13 a little bit. Zelda, no. So none of the tests I mentioned, Kingdom Hearts, correct. All right, Jumana, I'll get you a cookie after the foundation final. You have to find me and remind me though. So factor 13, none of the tests that we mentioned so far actually test for factor 13. Because remember what I told you guys, factor 13 is not doing its job until after the fibrin is formed, after the entire clotting cascade is done, right? So how do we test for factor 13? It's pretty simple, actually. We just do a clot solubility or a clot lysis test. And really all that you do in that is that you make the clot, all right? Then you add something to lyse the clot, all right? And you're going to have a normal patient, like a control, like a normal, something that you know is normal, and then you're going to have the patient sample, okay? So you're going to make the clot, you're going to add something to lyse the clot, and then you're going to measure how long it takes to lyse the clot. If the patient sample is lysing faster than the control, that means that there's a factor 13 deficiency because the fibrin is getting broken up faster than it should, which means that it's not strong, which means that factor 13 isn't there. So do we get how the testing for factor 13 is done? Yes. Okay, cool. By the way, reason this person is here is because he's from Organization 13 in Kingdom Hearts. I know I'm nerding out, but he's from Organization 13. That's why I put him there. That's how I would remember. I remember things in kind of weird ways, but it works for me. So second line tests, right? Now we talked about the first line test and how to check PT, APTT, etc. Second line tests is that you can just straight up do a factor assay. And what a factor assay is basically actually checking for the specific amount of each factor. All right. For example, if you do an APTT and the APTT is elevated, right? You don't know which factor is actually the problem. It might be one, it might be two, it could be all of them. So a factor assay is the way for you to confirm which factor it is. Or you could do a platelet function test. This is just, again, to check exactly how the platelets are functioning. All right. Those are just the second line tests. So just keep in mind, like, these are the second line tests. All right. So like, for example, let me just check the notes I wrote here to make sure. For example, yeah, you can. So if a person, for example, has PT, APTT, and their platelet count is all normal, but their bleeding time is prolonged, you know that it's a platelet function defect, right? So you would say maybe this person has Bernard Soliere or they have Glanzmann's. So you would want to do a platelet function test to make sure exactly what's the issue in the platelet. So you know the bleeding time is prolonged, so you know there's a platelet defect. So then you do a platelet function test to check exactly what's wrong with the platelets. Right, now let's talk about thrombosis. This is sort of like the last concept of this lecture, and I know we've been here for an hour and a half, so please bear with me. Do you guys want a break, or do you want me to just push through the end? Because I know I've been going for a minute, and we have practice questions. But I this is a heavy lecture. This is two lectures in one. Push through. All right. Okay. Oh, good motivation. Like you guys. All right. So thrombosis. Okay. We want hemostasis to activate when we need it. Of course, we want to stop the bleeding. But we also need to make sure that the blood flowing in our body is not interrupted inappropriately and we're forming clots that don't need to be there, or we're forming a clot and then the clot is just staying there. Because if the clot just stays there, we're going to mess up the blood flow in our body. Do you know what I mean? So this is something called thrombosis. Is when we're forming inappropriate clots in our body that is definitely going to mess with how blood is flowing. All right. So there is something called Virchow's triad for thrombosis. All right. Which basically means these are the three things that, if present, they're probably going to have a thrombus formed. And a thrombus, again, is like a clot that shouldn't be there. All right. Or they're going to have thrombosis. So if you have endothelial injury, right, which is any injury to the vessels, if you're in a hypercoagulable state, and what does a hypercoagulable state mean? It just means that the patients have a change in sort of the constituents in their blood, and that is making it so that clots are being formed faster. So maybe they don't have anything to lyse the clots after they're formed. Maybe they have, defective stuff. You know what I mean? Like basically their body is in a state where they should be coagulated. The body is in a state where there's more likely to be coagulation than anticoagulation. Do you guys understand what I mean by hypercoagulable state? Okay, yes. All right. The other thing in Virchow's triad is abnormal blood flow. And we're going to talk about how blood flow is normally and how blood flow is abnormally. And so if you have basically 2 out of 3 of these, then it's most likely that you're going to form a thrombus. Can I explain? So what's sclerosis versus thrombosis? They both cause strokes. So sclerosis is like an abnormal hardening, or like it's just gets abnormally hard. And sclerosis usually is on tissues, but thrombosis is the formation of like a blood clot, and a thrombosis is inappropriate, like in an inappropriate place, like it shouldn't be there. That's the difference. They both cause strokes. I think yes, they can both cause strokes. Can you re-explain it, please? Yes. So this is Virchow's triad, right? And so there's this guy, his name is Virchow, and he was like, hey, these are the 3 things that if the patient has them, they're probably going to have a thrombus formation, or their body becomes more likely to form thrombi, which that shouldn't be there. So that's an endothelial injury, so an injury to the blood vessels, a hypercoagulable state, which means that their body is more likely to form blood clots than be balanced, or abnormal blood flow. Okay, here, this is Virchow's triad over here, these 3 ductlets. So do we get Virchow's triad? And then usually if a person has 2 out of 3 of these, they're likely going to form a thrombus. That shouldn't be there. Okay, moving on. Here's just sort of a picture of thrombus. This is, again, a confusing hematological diagram. But after I explain everything on your own time, you guys can come back to this picture and try to understand it a little better. Let's talk about anti-clotting. Now, we know that when we form a clot, great, we stop the bleeding, but we don't want to stop the bleeding forever. So again, hemostasis is a balance in our body. We have things in our body that are going to cause the clot to break down. All right. And there are a couple things into this. First, there's something called cascade inhibition or cascade inhibitors. And what these mean is that they're going to go to the clotting factors themselves, right? And they are going to stop the clotting factors from ever doing their job or from continuing to doing their job. So we have, for example, the tissue factor pathway inhibitor, right? Or we have antithrombin 3, or we have protein C and protein S. And I'm going to talk about each of these things and how they function. But these are the things that kind of stop the clotting cascade from working at all. All right. They're like, okay, hey, you formed the clot. It's time to stop. We don't need this clot formed anymore. Enough. All right. So we understand cascade inhibition now. I have not spoken this poorly ever in my life, by the way. I don't know. I can't pronounce anything. You guys get what cascade inhibition is? Okay, cool. Now, the next thing is something called clot lysis. So, great, we formed the clot and we inhibited the cascade. The clotting cascade is not going anymore. But what about the clot that's formed? We can't just keep it there. So, we have these things that are going to come in and they are going to actually destroy the clot. All right, so this is something called tissue plasminogen activator and plasmin. All right. So these 2 things, I'm sorry, excuse me, these 2 things are what are going to lyse or break down the clot that was formed. Is that clear? Okay, cool. And so remember how I was talking about earlier, the hypercoagulable state? An issue with any of these is going to put the patient in a hypercoagulable state because they're not able to stop this coagulation from happening. So do you guys get, now you guys kind of get hypercoagulable states a little better? And we understand anti-clotting. Awesome, awesome. We're in the like the final stretch, you guys. So Fibrinolysis, let's go over it one by one. Fibrinolysis, breaking down the word, breakdown of fibrin. So tissue plasminogen activator comes in, right? There's something called plasminogen, all right? Now, in the name of tissue plasminogen activator, it's going to activate plasminogen into plasmin, all right? Plasmin is going to go and lyse fibrin, all right? And other things, just focus on fibrin, honestly. So plasmin is going to go break down fibrin. And then when you break down fibrin, it's broken down into two things called fibrin degradation products and D-dimers. Now, this is a little bit above the scope of your level, but I chose to include it just because I think it's okay to know at this point. These are the two things that fibrin is broken down into. They're called fibrin degradation products and D-dimers. And so if you ever want to look in a patient, how much are they breaking down their clots? Are they breaking down their clots more than they need to? Then you can check the levels of these, because if there's a lot of clot breakdown happening, that means that these levels are going to be elevated. All right. So we get what's happening with how tissue plasminogen activator, or TPA, is converting plasminogen to plasmin. Yes, yes. Okay. And then here's a little other fun fact for you guys. Sometimes when people have strokes, right, a lot of the time, the reason for that stroke is because of an inappropriate thrombus formation, or, something is stopping the blood from reaching the brain. So one of the things that they do is they actually give them tissue plasminogen activator to activate plasminogen into plasmin to go break down whatever is causing that stroke. All right. So that's like a clinical connection orientation for you guys. All right. Now, obviously, we don't want the plasmin to be activated forever. So we have something called alpha-2 antiplasmin, which is just going to go and inactivate the plasmin. Just stop it from... After the plasmin finishes doing its job, it broke down the clot, it broke down the fibrin. Alpha-2 antiplasmin is going to come and be like, okay, enough. Do not break down any more clots. You're done. You're finished your job. And then it's going to inactivate it. So now we understand everything that's going into fibrinolysis. Yes. I'm looking for yeses. Okay. Can you repeat it quickly? Of course. So basically, we have tissue plasminogen activator right here. This activates plasminogen into plasmin. Plasmin goes to the fibrin plug, or the fibrin clot, and it breaks it down. And when fibrin is broken down, it's broken down into fibrin degradation products, and it's broken down into D-dimer. So if you ever need to measure how much breakdown of clots is happening in a patient, you measure the levels of fibrin degradation or D-dimer. Okay? After plasmin finishes its job of breaking things down, alpha-2 antiplasmin comes and stops it. And it says, okay, you broke the clot down, you don't need to work anymore. So is that clear? Okay. So now, and this is a very confusing diagram, I know, but I'm going to tell you exactly what you guys need to understand from this diagram. So we basically have tissue factor. I'm going to maybe change the color. Ooh, I'll change the color to blue. All right, so you have tissue factor pathway inhibitor, which in the name inhibits tissue factor, right? So that kind of stops the extrinsic pathway. And then you have protein C, and protein C inhibits activated factor 8, and it inhibits activated factor 5. So it's going for both the intrinsic and the common pathway. All right. Now, I said protein S as well. Protein S actually is needed for protein C to work. Okay. So even though protein S doesn't directly inhibit any of the clotting cascade, protein S is needed so that protein C can work. Okay. So tissue factor pathway inhibitor inhibits tissue factor. Protein C inhibits activated factor 8 and it inhibits activated factor 5. Antithrombin 3 inhibits a lot of things. You don't really need to remember what antithrombin 3 inhibits. You just need to know that it's inhibiting a lot of things in the clotting cascade. But from this diagram, you can see that it's inhibiting activated factor 7. It's inhibiting activated factor 9. It's inhibiting activated factor 11. And it's inhibiting activated factor 10 and thrombin. So antithrombin 3 it's doing a lot. But what you really should remember is tissue factor pathway inhibitor and protein C. Those are the two key ones you need to remember for your exam. So do we get what these clotting factor things are doing? Okay, so yeah, I'll repeat. So this is cascade inhibition or the clotting factor cascade inhibitors. So the two key ones you guys should remember is tissue factor plasminogen activator, or I'm losing focus. I'm sorry. It's fine. I know this is a really long lecture. We're like literally at the end though. There's like a few practice questions and then we're done. So there's tissue factor pathway inhibitor, which is going to inhibit tissue factor. And there is protein C, which is going to inhibit activated factor 8 and activated factor 5. Those are the ones I want you guys to remember. And then protein C needs protein S to work. Okay? All right. To the person who asked me to repeat, did you get it? Okay, cool. So what happens if protein C is deficient? Yes, exactly. Factor 8 will not be inhibited and more clot will be formed. Both factor 8 and factor 5 are not going to get inhibited and more clots are going to be formed. Exactly. So that means that the patient is likely going to develop a thrombus. Perfect. Good job. So very just like sort of summed up version, any disturbance in the balance between prothrombotic formation and antithrombotic formation is going to cause local clotting events. Just anything that might mess that up is going to cause this. Now we're going to quickly talk about blood flow, which is the last thing in the Virchow's triad. So this is how this laminar flow is how our blood looks normally, okay? And the blood flows in this way for a very specific reason. And it's because in the middle, right? Do you see these arrows over here in the middle? So in the middle here, right, is platelets and other cell elements, okay? And the reason that we put the platelets and stuff here, most important for this lecture, is the platelets. The reason we put the platelets here is because we want to keep the platelets away from the endothelium. Because remember, the endothelium is where the injury is. It's where the von Willebrand factor is. It's where all of those things are. So we want to keep the platelets away from them. That way, we're never going to have like inappropriate clot formation, okay? And then over here on the outside, we just have plasma, which is flowing slowly, and it's kind of acting like a barrier between the cell elements and the endothelium. So that's laminar flow. That's how flow should be going in our body at all times. But if there is damage, if there is a disease or something wrong with the blood flow, you're going to have something called turbulent flow. All right. And it's in the name. You've heard like turbulence on airplanes where it's like doesn't make that sound, but that's what it happens. That's what turbulent flow is. And the issue with turbulent flow is that the platelets are going to come into contact with the endothelium, which means inappropriate clot formation is going to happen. And you're going to have decreased washout. And what I mean is that the blood flow is what's carrying all the clotting factors. It's what's carrying all the things that inhibit the clotting factors. It's carrying all the things that break down the clots. But if the blood flow is messed up, if you have turbulent flow, you're not actually moving the blood around. So you're not ever going to get those things to where they need to be. So once they activate, it's going to take a long time for this stuff to break down the clot and this stuff to inactivate the clotting factors to actually reach the location. Do you guys get what I mean by decreased washout? I need a yes or a no. Okay, cool. Moving on. This is sort of just the text version of what I just said to you guys. Turbulence is going to cause thrombosis because there's endothelial dysfunction and pockets of stasis. And stasis just means areas where blood is not moving. And then here it's just a comment to know. Stasis is a big contributor to the formation of venous thrombosis or venous thrombi. So over here, you can see the stasis a bit. Do you see how there's areas here where the blood is not actually moving? That's stasis. It's stuck in that area. That's just in areas of stasis, there's probably going to be an issue with clotting. This is the last slide, all right? Here are just some examples of hypercoagulable states. We went over most of them. There is a disease called factor V Leiden. Not super high yield, but I guess it's important to know. All that it is that it's a genetic disease where your factor V gets resistance to being cleaved by protein C. Because remember, protein C acts on factor V and factor VIII. And this disease, factor V doesn't get inactivated by protein C. So you're going to be in a state where there's more coagulation. If you have a deficiency in antithrombin 3, you're not going to be able to inactivate the clotting factors. You're going to be in a hypercoagulable state. If you have a protein C or a protein S deficiency, you're going to be in a hypercoagulable state. Okay, these are the genetic causes of hypercoagulable states. The acquired causes or the secondary causes is, like we mentioned, things like stasis. So if you're in bed after a surgery or you're not able to move, you're gonna have more stasis in your blood flow. You're likely gonna form a clot. If you have an injury to your tissue in your body, you're likely gonna have a blood clot. And then cancer does a whole lot of things to the body that you're going to learn about throughout medicine. One of those things is that it puts the body in a hypercoagulable state. So do we understand this slide about hypercoagulable states and what they mean and what they could be? Oh, what did I just do? Do we get it? Yes, yes. Okay, you guys answered fast this time. I think that means you actually got it. Now, to end off this lecture, practice questions. So I will read it and I want you guys to type in the chat what you think the answer is. So a young boy has bleeding that stops and then starts again after a delay. Further testing was done and it was found that he has a factor 13 deficiency. Which of the following is most likely to be observed? So tell me the answer. And these are the style of questions you're going to get on your exams. All right, I'm seeing D. What else? I want to see more answers. There's 15 of you here. Although two of them are me and one of them is the host. All right, D, anything else? 5 more seconds. 5, 4, 3, 2, 1. Correct. The answer is D. Remember, we said that a factor 13's whole function is to make the clot stronger, right? And this person is having bleeding that stops and then starts again after a delay. I even put the keyword for you guys in there. And when we do a test for factor 13 deficiency, we're going to see that the patient's clots is lysed way faster. So they're going to have a decreased clot lysis time. All right. Does everyone understand why this answer is D? Does anyone not understand it? Okay, thumbs up. Can you explain why it's not B? Prolonged whole blood clotting time. The reason why it's not B is because a prolonged whole blood clotting time means that everything in the blood clotting, prolonged whole blood clotting time means that it's taking a really long time for the blood to clot initially. Here, the blood clotted just fine at the beginning. It stopped. But then it rebled. That's why it's not a prolonged whole blood clotting time. So B means A and C, right? It can be. It can mean A and C. Okay. I'm gonna go to the next question. Which of the following is directly responsible for the lysis of insoluble fibrin? You're welcome. All right. I saw one answer. I want to see some more. Let me get one more answer and then I'll reveal it. Come on. Don't be shy. We're here. We're all here to learn. I don't bite. E. Okay. The correct answer is C. So I saw B and E in the chat. Let's talk about why it's not B and E. B, plasminogen, is the inactivated form of plasmin, right? And so B requires something called tissue plasminogen activator in order to become plasmin. When it becomes plasmin, that's the one that's breaking down the clot. Fibrinogen is the inactive form of fibrin. All right, so fibrinogen becomes fibrin. Fibrin is what the clot is. So if fibrin is what the clot is, that means it's not the one directly responsible for the lysis of the clot. So do we all understand why the answer to this question is C? Okay, cool. Moving on to the next question. In patients with autoimmune thrombocytopenic purpura, antibodies are made against GP2B3A. Which choice below is the mechanism for the subdermal bleeding in these patients? Think about it. This is a little bit of a tricky one. Any other? Okay, A, E, E, E because, yeah.
Yeah, okay, I'll think about it.
So lack of platelet aggregation, or E, is the answer. All right. So what does this mean? It's because I zoomed in. GP2B3A is responsible. Remember, let me redraw that picture for you guys. Oops. GP2B3A is responsible for platelets to aggregate and connect to each other. So if you have antibodies or things that are destroying GP2B3A, that means you're not going to have platelet aggregation. All right. So we all understand why this is E. Okay, cool. I think there's two more questions. So a 2-year-old boy presents with prolonged bleeding post-circumcision, and his physical exam shows small bruises on the legs. His coagulation profile showed a prolonged PT and a PTT, but a normal platelet count. So which of the following coagulation factors is most likely to be deficient? Guys, think about this. Why are we saying A? Prolonged PT and APTT. What did we say a prolonged PT and APTT most likely indicates? Exactly, the common pathway. Von Willebrand factor carries factor 8, which is in the intrinsic pathway, which means that only APTT would be elevated. So with that in mind, I've eliminated one of the answers for you guys. What is it now? Okay, correct. The answer is factor 2. All right, so guys, remember that a prolonged PT and APTT most likely means common pathway is there's an issue in the common pathway. So that's not that. Factor 7 is the extrinsic pathway. Factor 8 is the intrinsic pathway. Factor 9 is the intrinsic pathway. That just leaves us with factor 2. All right. We understand this. I know we all chose A initially, but do we understand why it's B? Yes. Okay, I'm kidding. Now we have 2 more questions, I think. I know I put a lot of questions. That's because you're going to get a lot of questions about this lecture in your exam. 63-year-old man takes aspirin. I shouldn't have emphasized that. I shouldn't have told you guys. It's important to relieve pain in his hips and knees. He had a surgery, and after the procedure, there is profuse bleeding time or bleeding from the site of surgery. A coagulation profile shows an APTT of 34 seconds, which is within the normal range, and a PT of 13 seconds, which is within the normal range. Platelet count is 350, and bleeding time is more than 15 minutes. Which of the following is likely responsible? You guys answered before I could even finish reading it. Correct. It is a platelet function disorder. Someone quickly tell me, what does aspirin inhibit? Exactly. Okay, I'm glad that that concept stuck in your head. Okay, this question is the last question. A 15-year-old girl presented with an increased bleeding during menses, which is the first period, since the last 3 years. The laboratory investigation shows a bleeding time of 5 minutes, which is normal, a prothrombin time of 11 seconds, which is normal, and an APTT of 120 seconds, and a normal platelet count. The most likely cause of this abnormal bleeding is the patient's deficiency of. This is a very tricky question, you guys. So take a second and think about it. Like, I think this is the trickiest it could get, honestly. Let me get like 2 more answers and then we're going to discuss the question. Okay, I got 2 more answers. The correct answer is C. So we have a female patient who is having an prolonged APTT. And remember in that slide, I said the most likely thing that a female is going to have is a factor 11 deficiency. All right. The reason I say this question is so tricky is because a lot of people put in their head that because a patient has prolonged APTT and the most common thing is factor 8, then it's a factor 8 deficiency. But it's not a factor 8 deficiency. It's most likely not a factor 8 deficiency because she's a female. If I said this patient was a male, then it was probably a factor 8 deficiency. So do we understand why it's factor 11? Okay. Fun fact about this question, this was in our TBL in first year, and 160 people chose factor B, and I think maybe only 40 people chose factor C, or option C. So more people got this question wrong than right during our TBL. That's why I wanted to include it. With that, I'm done. I have finished Hemostasis, the alleged hardest lecture of Heme Onc or HLS. I will stick around for like 10, 15 minutes to answer any questions. Here are my contact information. And I will send the slides and have those shared with you guys on your announcements group. And yeah, if you guys have any questions, feel free to ask, whether about the lecture or whether about first year advice studying. This is the part where I do therapy for the people. You explained so well. Thank you so much. Of course, of course. Yeah, I'll stick around for a little therapy session to those who need it. I think we can stop the recording. I guess, yeah, we're done, unless there's any questions, which I don't think there are.